And we're live.
All right, good morning. This is Senate Health and Welfare. It is Friday, February 21st, the day before in history that George Washington gave his farewell speech to the full Congress, which we read a little bit yesterday, so we won't do that again. So I think you know everyone around the table.
Yeah.
So today we're going to be looking at our committee bill, and we're beginning to formulate better and better ideas about it as we hear from folks who are giving offering improvement. That's good. So first up is David Berman. Thanks for being here.
Yeah, thanks for having me. So for the record, David Berman, and I'm a board member of the Green Mountain Care Board. That I speak on behalf of myself and not on the board in this situation.
Okay.
But let's give you my thoughts on this. I think so. What I think I'm speaking to is talking about part 4 of the committee bill, hospital budgets and payment reform section. And just some general thoughts on this is that I do think that overall in healthcare in Vermont, we've talked a lot about payer alignment. But I also think we need to think a lot about incentive alignment, that not just the payers are aligned, but that the providers and the incentive systems that are aligned with providers or that providers have are aligned with the state goals where we're trying to go. I think that's the goal of much of health reform. I think it also has come up a little bit in compensation alignment, that we work to ensure that the incentives that are being used for compensation align with the goals of the state. I think that is a really important part. I think the way I've been thinking is we've been talking about 2 canoes for a long period of time with 1 foot in each canoe, and I just want to make sure the canoes are going down the same stream, that we're all moving in the same direction, even if we're trying to figure out our wobbly stance that we have. Okay, so the first section of part 4 talks about reference-based pricing, and I think that so there's a lot of policy discussion here, and I wanted to sort of just break it down to the basics. With reference-based pricing, the way I think about it is it's a method to standardize prices paid for healthcare services. And the term references to Medicare as a base price, and then as a multiple of Medicare. For instance, in 2022, according to RAND, Vermont paid about 282% of Medicare prices overall, where the national average is about 246% for Medicare prices. And I think one of the things that I like, and I think many of the board members like about reference-based pricing, is it addresses prices directly. So I think we have a lot of concern that we have a pricing problem within healthcare, that prices differentials between institutions and for services is massive, and some of them are very, very high, especially on services that are being utilized more frequently, like CT and MRI imaging services that are high margin services. It leads to equity within payments across services. It allows supporting for a specific area. It allows us to sort of support up prices, and that's really mentioned in the bill here, which I really appreciate. Is the second bullet that I have is that requires that support. So I think there are some really helpful things with that. My general asks. Oh, and I also want to differentiate a little bit of this. When I look at this, and I think what we're trying to do here is look at reference-based pricing for the entire system, all hospitals, including non-hospital payments. That's different than what we have looked at with this. That you appropriated us funds to look at the state employees and teachers union. That is a subset, and so it's a different. Those things can happen in tandem. They can align out a couple of years, but I think they're 2 separate things. I just wanted to clarify that. I think you guys clearly understand that, but I just want to make sure that was said. So sort of my ask when I look at this is that we have dates in most every other section here for GMC regulatory duties and hospital gold budget. We didn't have dates in the reference-based pricing. I think we should consider a timeline for this as well. It'd be taught, and I'm happy to send you my thoughts on this, but I think it's possible.
No, do that, and because it hasn't escaped us that it can't happen.
Yeah, and it's going to take a time for, stakeholder engagement or, the process of that,
Right.
rule making, guidance making, and then getting into a budgetary process.
And I don't know how much you've talked about this with the board, and I know that Owen is listening and he's on with us, but not with us. But the what resources are needed in order to accomplish some of these things. So we haven't actually dived down into the budget part of the bill yet, but as you're looking at the timeline, it would be helpful to get some thoughts.
Absolutely.
Okay.
Yes. So that is my general thoughts on the reference-based pricing section. The total cost of care section, I think is a great idea. I'm really happy that you put this in here. I think setting targets for spending is really important. I would just also like to add in this a small thing is that I think we need to be mindful that we've looked at total cost of care within the all-payer model. And the first few years of the all-payer model, we look at Medicare revenue coming into the state was sort of flat or maybe downtrending slightly, but our total cost of care was growing at the projected rate, which meant that commercial was making up that difference.
Yeah.
So I think that while looking at all payer total cost of care is super important, I think we should also think about that commercial total cost of care or a commercial spend target or tracking that as well, so that we understand what portion of that is being put on to, businesses, individuals, taxpayers. And we could look at Medicaid and Medicare and just have three separate sections of that too, so that we can keep an eye on the components of the total as well.
So it's a matter of really looking at what's going on with each. It's difficult. You can't regulate each one, but AHS can do it. But yeah, I get it.
Yeah, but I mean, say for instance, we saw a massive spike in Medicaid, and the legislature didn't want to.
Right.
We would want to know that, but I think really it's commercial is the one that gets a little bit obscured.
They're kind of the fallback for filling the gaps.
Yeah.
Yeah.
With the other thing in the total cost of care and this is totally my opinion reading this, is that we talked about establishing targets for primary care, preventive health care spend, mental health care spend. I think this is incredibly important and really valuable to do. I want to make sure that when we set those targets that we can compare them, and I don't know if this is appropriate for the bill or for just when but to compare them, to be able to compare them to other states, so that we don't have our unique Vermont definition that we're using and then we're using a standard definition in the comparison group, that we use a definition that allows us to compare. I think it's important to think about, we spend a lot of money and effort in Vermont on things like blueprint and the coordination of care that may not be represented in some of the other metrics, but I think we also still need to be able to have a comparison metric to other states.
And it depends on which states. You can pick states that really resonate with what's happening here and you say, oh, we're fine. Reality is we're destroying our economy at the same time. So, yeah. So, yes. So I don't want to pick the states. I'll let the board think about that.
Yeah, and I think that's something that I think a lot of people have looked into, and I know that there's the New England states and there's methodologies out there, but I just want to make sure that what we do is we have something that can compare us to others.
Right.
Okay, global budgets. I think probably we'll talk maybe more about global budgets today. The few things on global budgets. So generally speaking, global budgets is another way to pay for healthcare delivery. The United States of Maryland, I believe, is the only other state doing this. Conceptually speaking, you pay a lump sum to a hospital, and then they provide the services from that amount of money. That sum increases by an inflationary metric. It has some really big advantages that you define what your cost growth is going to be, and it sticks with that. And it avoids sort of the impacts of overutilization. So like, they call it induced utilization. So hospitals or providers trying to pull in a whole lot of high revenue procedures, they're not going to get more money for that. Or if they do, it's going to be a very kind of an incremental process that's regulated. It sort of undoes some of the risks of upcoding, of providers increasing their documentation intensity to try to get more money for the same service. It has the disadvantages and the risks so that it could induce hospitals to want to reduce services to try to make their margin at the end of the year. And so I think this was really thoughtful about including language to establish outcome measures for hospital costs and appropriate quality and access measures. So I think that I really appreciate that language in there. That's sort of my general view of global budgets and sort of the broad benefits and the broad risks. When I look at this, the one thing that really struck out to me is something that, and I think that, global budgets have a lot of promise in the sense that you can avoid the problems of this overutilization that is a risk in sort of the fee for service rubric. To me, what I look at this bill is I was worried about the timing. So starting in 26, and if that's FY26, that's today, right? Our guidance is.
That might be a little quick.
So I think we should think about pushing back the timing and my view.
Wait. Remember, I started writing this thing in September, I think, before I got COVID. So.
And that's great. And I think there's a difference between and I think we should clarify whether it's like calendar year or fiscal year.
Yeah.
Because the fiscal year, if we in 26 start to implement global budgets, that would be FY27. But if we're trying to implement them for FY26, that's today it needs to be up and running.
Okay.
And so I can send you some thoughts on timing. My general view of this is that I think there's some advantages to running a rate setting methodology like reference-based pricing for a few years and reducing the variance in price and then moving into global budgets. So I kind of see this as a sequential process. Not that reference-based pricing goes away in global budgets. I think you can run that as your sort of basis of how we think about how much money should lead to a budget. But I think if we can correct some of the pricing outliers in a few years and then move into a global budget, I think we're much more likely to have success in those budgets, in those global budgets. The other thing I want to point out in global budgets too is I think this is complicated stuff, and there's going to be, and so I think that impacts the timing. There's going to be stakeholder engagement, rulemaking, all of those sorts of things, and making sure we get all that outcome measures that you put in here. So that was my thoughts on global budgets, and I'm happy to send you thoughts on timing.
That would be useful, really, because you understand the work and the time and the resources needed to accomplish some of this.
Yeah. Okay. And then the last section is the GMCB regulatory duties. And I think, again, if I could send you comments on this, I think would be most helpful. But there's some timing stuff in here too. So in this, starting in 2026, there's a few things that I think we could pull off in 2026. But the first one, which is which I think is great to have a statewide strategic plan and then hospitals build strategic plans off of that. But if we pass the bill in June, I think an optimistic 6 months to get a statewide strategic plan, 3 months to get a hospital strategic plan. I think we're talking like light speed here.
Yeah.
Then I think we're looking more towards 27 than 26. But there are other things that I think we could start to work on and move towards being functional in 26. So I'm happy to send you some thoughts on the dates on those sorts of things. But that was my main thrust of commentary on the regulatory duty section. But
thank you.
Other than thank you.
Yeah, no, it's really helpful. Thanks. And just before I go to Senator Bullock, we have folks coming in on S63 next week, so I won't ask you that question. But we'll go to Senator Bullock.
Oh, okay. Thank you. Thank you, Chair. And thank you for the testimony. This is more of just musings rather than a question. Senator Cummings and I are both on the Finance Committee, and we're dealing with education finance a lot these days. And one of the things that we've noticed that's missing from the education plan is like dealing with cost drivers. And we know that healthcare is a big cost driver, not just in education, but just affordability overall in the state. And it's having a huge impact actually on how we're going to redo education in the state, which is giving some of us pause to say the least. So I hear you about a thoughtful timeline and doing this right and not rushing it. And I also just hope that we can continually remind people of the urgency that we have right now and the ripple effects.
I totally agree. I think that with regards to education and the reference-based pricing, study still interest in that area. I think that could occur before a broad system-wide reference-based pricing. We just need to be thoughtful about how to do it. And of course, that's what you do. So, but I think that it has some significant potential to help mitigate some of those cost drivers in education.
Well, but we don't want to see it as the solution, because once people start to feel comfortable with their property taxes, then that seems like the solution. And so I'm just cautioning us that, yeah, we can do that, but we can't leave out the next steps. I'm agreeing with you, but I'm just saying you can't leave out the next steps. That's been my concern from the beginning. So my ask of you is, please send your comments, and there's that little acronym ASAP. We are trying to work as quickly as possible. And I know you're extremely busy, but if you can do that, would be really
great. Yeah.
Other questions for Dave? Thank you. I mean, you're getting into the heart of what we need to do to put this into language. And then after we get it into language, there'll be other, I was going to say fine tuning. It's not yet major tuning, and then fine tuning. So thank you.
Thanks.
Great.
So when we discuss the difference between long-term solutions and short-term solutions, what is the time frame on both of those? Is like 26, 27, is that short-term or is that long-term?
Short-term.
That's short-term. Okay.
Yeah. So right now we are in appropriations. We are building the 26 budget.
Okay.
So anything we do here with implications for the 26 budget is kind of the short term.
Okay. This does a lot. If this is the short-term plan, then.
Well, this isn't the short term. There are pieces. Well, we could talk about that after we've had testimony today. That's a good question, Senator.
Yeah.
But this has both short and long term, but they go together. Yeah. Thank you.
Thanks.
That's good.
Thanks.
All right. So we are really fortunate. This committee understands the need for data and questions that we ask when we are using evidence for our decision making, and we have a little set of recommendations up on our wall that come from the Milbank Fund. And thank you for that, John. And we are really fortunate to have John Colmers here with us, from the chair of the Milbank Fund. So welcome. I'm going to have the committee go around and introduce themselves to you, and then we'll have you introduce yourself and share with us your information. So Senator Hart, go right ahead.
Good morning, Senator Hart from Orange County.
Senator Sam Douglas from the Orleans County District, representing 20 counties.
Ginny Lyons, Chittenden Southeast.
Good morning, John. Senator Martine LaRocque-Ulick, Chittenden Central.
And Ed Cummings, right here in Washington County. So you have an eclectic group, and we've been working on all of this for a while now, and we're really thankful that you've come in to share with us what you know, and maybe give a little bit of your background so folks understand who you are and where your evidence and information is coming from.
Okay, thank you very much. It's indeed a pleasure for me to be here. Let me see if I can get my slides up.
That's my testimony today.
You,
Okay, I assume you can all see my slide deck?
yes,
Can you see that?
yeah,
Okay, okay.
perfect.
Okay,
It's
great,
perfect.
perfect. So, again, my name is John Colmers. I'm going to briefly give a outline so you can know what to expect and what I will be covering today. I'll focus a lot of my attention on the work that has been done in Maryland. We'll talk about the history of rate setting in Maryland, what the structure looks like, how it's performed, the tools that are necessary in order for it to work. I'm then going to give a clear-eyed SWOT analysis looking at the strengths, weaknesses, opportunities, and threats associated with the method, and certainly able to answer questions. A little bit about my background. I have spent much of my career, had spent much of my career in state government. I started to work for the Hospital Rate Setting Commission in 1981. By the looks of the committee, that was while you were probably all still in high school. I
So a couple of us not.
That's usually the effect that I like to get. Yes, so I've been at this a long time. Was the executive director of the commission. I also ran another regulatory commission in Maryland overseeing small group insurance market reform. I did my undergraduate work at Johns Hopkins, master's in public health from Chapel Hill, doctoral work in health economics back at Hopkins. While in the midst of working on my dissertation, I started to work at the Rate Setting Commission. I then left state government after 19 years to spend 6 years at the Milbank Memorial Fund, where I was a senior program officer, and then was asked to become secretary of the Department of Health and Mental Hygiene in Maryland. The Maryland Department of Health is the agency that oversees Medicaid and all of the health regulatory and oversight functions in the state, including the public mental health, substance abuse, and developmental disabilities organizations and activities within the state, the largest single agency in the state. I did that for 4 years. I had the wisdom to do that during the worst economic downturn since the Great Depression. So I spent a lot of time cutting budgets and making changes there. After leaving while I was in state government, I should say I became the chair of the Blue Cross of Maryland board. It was at a time when the Blue Cross was attempting to go private, sell itself private, and the insurance commissioner turned that request down, and the legislature demanded that the board be turned over, and I was made chairman of the board of Blue Cross of Maryland and on the board of the holding company as well. I then left state government and became for 10 years the senior VP for strategic planning for Johns Hopkins Medicine in Baltimore. I retired about 4 years ago. I've been on the board at Milbank for about 8 years now, and I currently chair that board. You heard from Chris Kohler recently, who is the CEO of the organization, and one of the areas that the fund has played a great deal of attention to is on the issue of healthcare costs and affordability. I, of course, in my life at Milbank and before, have paid a lot of attention to what is going on in Vermont. As I told the chair, I have spent every summer of my life since I was 3 weeks old in the state of Vermont. My grandparents bought a place in Vermont in 1949 outside of Woodstock, and I've been going there ever since. So I have a very fond place in my heart for the state, obviously, and know it, I would say, peripherally, but certainly I followed the politics here. So that's who I am, and that's what I'll talk about. I also am, in my retirement, do some consulting with the Berkeley Research Group. You may be familiar with them, as they have done some work over the years with their Green Mountain Care Board. So let's get started. This is Maryland, a little bit different in shape and location than Vermont. They talk about it as being America in miniature. We have rural areas on the eastern shore and in western Maryland, many significant suburban areas, particularly surrounding Washington, D.C., and particularly as they have expanded outwards, and an urban core with all that goes with it in the city of Baltimore. So a complex complex state with lots of different healthcare needs that are different around the state. We have been doing things differently in Maryland with respect to hospital spending since the early 1970s, enabling legislation that created the Health Services Cost Review Commission was enacted in 1971. Rate Setting Commission itself is a 7-member commission. It is an independent commission, meaning that the decisions of the commission are appealable directly to the courts. It's not independent of state government. Its budget goes through the legislature. It is presented by the governor. Members of the commission are appointed by the governor to serve 4-year staggered terms. The model itself has been described as a public utility model of regulation. Hospitals in many jurisdictions, if not monopolies, that is to say, the only player in town, are often oligopolies. There may be a few large health systems around, and as a result, tend to be exhibit that behavior and the ability to set prices as opposed to a competitive environment where prices are set by the market. The commission serves both as a watchdog and a regulator. We have had what is called a Medicare waiver since the mid-1970s. Since 1977, we have been an all-payer system. What that means simply is that all payers, Medicare, Medicaid, commercial insurance, the self-pay, individual market, and the uninsured all pay the same rates for the same service at the same hospital. Now, let me be clear here, that does not mean the rates are the same across all hospitals. The rates at Johns Hopkins Hospital in an international academic medical center are very different than the rates at Hospital Frostburg out in Western Maryland. They are different sets of rates, but once you are at that hospital, what Medicare pays, what Medicaid pays, what commercial insurers pay, what the uninsured pay are exactly the same. And it's called a waiver because hospitals are waived from Medicare and Medicaid payment rules, and the state sets the rates for commercial insurers and others. Since 1977, a long time, all payers participate. We are unique in the country in doing this. The value of the all-payer system is that it provides cost containment. We'll talk about the ways in which you measure that and what the results have been. It results in an equitable funding of uncompensated care because included in the costs of a hospital are the reasonable costs for caring for patients who do not have health insurance. That is a lesser concern today after the Affordable Care Act than it was in the past. Maryland is one of the states that did expand Medicaid as a result of the ACA. So our uninsured rate has declined, but it clearly is not zero, and there remains uncompensated care from people who have no insurance or who are underinsured. It produces a stable and predictable payment system for hospitals that they know, generally speaking, what their rates will be and how they will be set for the coming years, so they can focus their attention not as much on the revenue side of the equation, but on the expense side. All payers help fund graduate medical education. They help fund the costs of having 2 major academic medical centers, University of Maryland and Johns Hopkins in the state, and the training of future physicians. We also have programs in place to help fund a nurse education support program in particular to assist not only students in their funding, but to support nursing training at the nursing schools through a provision in rates that supports specific programs. We believe in transparency. It's one of the values of having an government type of oversight and making it transparent. Government is not the only way in which you can do transparency, but it certainly helps. We have been a leader in Maryland in linking quality and payment mechanisms so that the way in which you get paid is directly tied to the way to the quality that you are providing as measured in a variety of fashions. Hospitals have local access to regulators. They are in constant contact with the commission, and because there is that single set of payment rules, they are not addressing that separately to the Medicaid agency, to Medicare at CMS. They are not talking to individual commercial payers. It's a single sort of source of contact, and it avoids cost shifting among payers. And so you've referenced pricing discussion earlier, the relative difference between Medicare payment levels and commercial payment levels. In Maryland, that largely does not exist on the hospital side. It does certainly on the non-hospital fees, and we'll talk about that in a moment so you can see that, but it does avoid cost shifting among the payers. Why did we start with hospitals, and why do we continue to focus on hospitals?
John,
Yep.
John, I'm not interrupting except to say that the GME is Graduate Medical Education, in case that acronym didn't resonate.
Thank you very much, Madam Chair. I apologize, and please stop me. We tend to speak in acronyms all the time, and you'll see quite a few in a moment. So I will try to avoid skipping over those. GME is Graduate Medical Education. The funding for physicians in training, residents, and a portion to cover the cost of those who are supervising them. And so why did we start with hospitals? And it is particularly for Medicare that more than 75% of Medicare expenditures are tied to a hospitalization. A little more than half is actually hospitals itself, but when you add on to it the post-acute care, the facility-related physician fees, it's a lot of the Medicare spend. And so if you are interested in controlling those costs, particularly for Medicare, it is an area where a lot of attention is played. Obviously, not exclusively. Obviously, if you are worried about preventive care and making sure that there are things that are avoiding the hospitalization, you want to make sure that there is sufficient there. Certainly laud the idea of being able to track and measure the primary care spend in the state. That too is something that the Milbank Fund and Chris in particular has been a strong advocate for. But hospitals are important for where the money currently is. This is a brief timeline. I won't go into great details. It does stretch back to 1971 when the enabling statute was written. I will say this for the committee's edification. Much of the enabling legislation for the commission is remarkably the same as it was in 1971. Yes, there have been changes over the years with respect to authority, with respect to bringing in components related to the global budget and so forth. But the basic elements of how the rates are established and set was done in broad language in 1971, and then interpreted. It was written so broadly that the commission could then move forward in ways that were that allowed it to evolve. And this evolution is, I think, clear in this timeline. The waiver happened in 1977. The commission began setting unit rates for hospitals, so how much they could charge for individual services. We moved to a per case payment system in the 1980s, as in particular as in advance actually of Medicare PPS. We began early on geographic payment, so along the idea of a global budget for hospitals in rural areas that were much more contained. In 2014, we negotiated with CMS for our global budget model. In 2018, we moved that model from just hospitals alone, which is what global budgets were, to a total cost of care model, and incorporated total cost of care is PCOC. MDPCP is our Maryland primary care program. So we have a program with the federal government that creates a primary care model for participating primary care practices around the state. A vast majority of primary care practices are participating in that. We have begun episode-based payment models. There are lots of complexities that began in 2018. I could spend hours talking about them. I won't. But just as a way of the timeline, in 18, we began total cost of care. And in 2024, at the end of the year of 24, we signed the HEAD contract with CMMI, much like Vermont did, and we shall see where we go with that. So I'm going to move on to what the regulatory ecosystem is, and then I'm going to pause to see if there are questions. So I've talked about the HSCRC, that I put a legend at the bottom to help with the acronyms. That is the Health Services Cost Review Commission. The commission sets rates for hospitals, unit rates. It establishes and enforces global budgets. So it's a mechanism not only to set what the global budgets are, but on an annual basis to assure that those global budgets are adhered to. It has, as I say, that statutory authority that has been broadly given to the commission by the board. The next regulatory commission, the next component is the Maryland Department of Health. That department does not have direct oversight over the commission, but coordinated activities. The secretary oversees, as I mentioned, the Medicaid program. It oversees the public mental health, public health infrastructure in the state, all the local health departments and population health activities, all of the health regulatory oversight, including the health boards and commissions, quality care. And the Maryland Primary Care Program, the MDPCP that I mentioned earlier, is monitored and established through the Office of the Maryland Department of Health. We'll talk about Maryland Health Improvement in a moment, but they are the ones that set what our health improvement goals are. It's not set by the rate setting commission, but the Department of Health sets our program for what do we want to improve and metrics associated with health improvement as a result of this model. The Maryland Healthcare Commission is what is our planning function in the state. We still have a certificate of need program, although CON, quite frankly, is largely limited at this point to very large capital projects, essentially replacement facility activities, and a few very high intensity clinical programs, such as open heart surgery or organ transplantation services. The MHCC, which I also was the executive director of for a period of time, also is the repository for all payer claims database in Maryland, and produces multiple reports on spending in the state. They also produce report cards on quality performance of various components of the state. HMOs operating in the state, nursing homes, hospitals, physicians, etc. This is really where that transparency of data is making that information available to the public at large. Here's another great acronym, the MIA. That is the Maryland Insurance Administration. They, like insurance administrators everywhere, have oversight over the fully insured insurance market in the state of Maryland, and provide oversight there. They also provide a degree of oversight with the Maryland Department of Health for the Medicaid managed care organization. A large portion of our Medicaid program are operated through private MCOs, or managed care organizations, and the MIA help provide financial oversight over theirs to make sure that they have sufficient capital and are operating in a way that they will continue. The final major structure, and although technically not a government agency, it's a quasi-government agency, is CRISP. This is our HIE, our Health Information Exchange in Maryland. CRISP stands for Chesapeake Regional Information System for our patients. CUTE. Their logo is a blue crab. It's kind of nice. We like our crabs in Maryland. It's not quite maple syrup, but it helps define who we are. It is, I highlight it here because I think it is such an essential element of who we are and what we do. And unlike other health information exchanges, because of the rate system, because of the quality mechanism, hospitals, physicians, and others rely on this clinical repository of information to understand where their patients are receiving care and how they are operating. So all hospitals have health electronic medical records. Many of them operate under Epic. Others use Cerner. Others use other proprietary systems. But if you're a physician in the community, you may not have access to the full record of a particular patient, and you may not know, for example, when one of your patients makes their way to the emergency room, for example. Well, one of the early case examples of how CRISP worked was that the moment the patient hit the emergency room, a notification could go out if the patient had registered with their primary care physician to that primary care physician, so they would know basically real time that their patient was in the emergency room. It is expanded to many other use case scenarios. It is a critical feature of who we are. As a result of the AHEAD model, there's the creation of the Maryland Commission on Health Equity, which is going to serve essentially as the coordinating function for all of these activities under AHEAD and how that is managed. AHEAD we'll talk about in a moment of where we see the model changing from the total cost of care model to AHEAD. And there are a variety of advisory committees which include ways in which various stakeholders can participate and influence the decision making. Because this is a legislative committee, I didn't want to ignore the fact that there is clear legislative authority that is granted to each and all of these areas and oversight that is done. So that is what the ecosystem looks like. Let me pause here and see if there are any questions about what it is we do, and I'll talk a little bit about how we do things.
So I will ask the question. So you obviously have regulatory entities that are regulating what's happening, whether it's the hospital or other rate setting. And then you also have administrative agencies and departments that are very much engaged in this. So how is it that this sort of system works? The collaborative process seems to be critically important. And I don't know that you need to answer the question in detail, but what are this maybe statutory or statutory rules or what's in place to knit this all together?
So and
I'm using the word knit because we have a very important knitter in our group.
I noticed that, and my spouse she is a knitter as well, and so just keep at it. So the way it's knit together, I think there are both formal and informal ways in which that happens. I would say to some degree on the formal level, there are requirements of coordination that the legislature puts in place. So the secretary can serve as a convener. The governor obviously serves as a convener. When I was secretary, I and the lieutenant governor, particularly around the time of the Affordable Care Act, convened a group that included the members of the legislature and members of the industry. This Maryland Commission on Health Equity was recently formed. It's already in place. Gubernatorial appointments includes members of the House, a member of the House, a member of the Senate, various members of these regulatory activities. And this is where that coordination by formal activity will take place. I will say it is also, and I think you're correct in understanding this, it is also the informal mechanisms that are critically important. You have to have, the governor has to make appointments to people who are willing to work with one another and to work collaboratively. I think part of the worry that folks had of centralizing everything within one organization would be that it would create too much authority in one small group. The commission, as I said, the rate setting commission is relatively small. It's 7 members overseeing, a $16 billion hospital industry. I'm an advocate of small rather than large, in that it is less likely that people are going to have to resort to putting on their hats on, depending on who they represent around a table. If you have a smaller number of people, you have to take a bigger view of things. That being said, I did not want to have the authority over all of these other things. There have been talks in the past, for example, of merging the HSCRC and the MHCC, so the planning function and the hospital function. And in many ways, having them separate is of value. You want to have the planning done in a way that not necessarily is driven exclusively by the financial considerations. You want to have these things separate, I think, from the department, because the department is a payer. The department is Medicaid. If they are overseeing things by themselves, they are going to have a particular view that may focus on Medicaid spending inappropriately to the disadvantage of others. So at least in Maryland, the history has been one of decentralization to this degree, but required coordination.
Thank you. That's the type of umbrella that we need to understand as we look at what we have in the state, and that is extremely helpful.
So moving along, let's talk about what are the tools that the Rate Setting Commission has. I will not go into detail. We would spend a week doing that, but I'm just going to describe briefly what they are. So there's a method that the commission has for actually setting rates for hospitals. So rates are set for all 40 plus hospitals within the state. Those rates are set and a global budget is established through a complex method. And once those global budgets and rates are set, they are updated each year in July, and they are updated for inflation. They're updated for quality performance. If you've improved or worsened your quality performance, you're adjusted to make sure that you're in compliance with your global budget. Here's another nasty acronym. The MPA is the Medicare Performance Adjustment. So in addition to the overall global budget, we have a budget requirement under the terms with CMMI that we make sure that everybody is paying to the amount up to Medicare that they've established in the contract. And you heard this alluded to earlier in the discussion from the Green Mountain Care Board, this is not a capitated payment system. People think of global budgets as a pile of money that gets sent in a quarterly basis to hospitals, and then we walk away. This is a system that still operates with fee-for-service payment under the umbrella of a global budget. So patients are still free to go where they want. They are not tied to a particular system. This is not like a HMO where people are in a closed network. People go where they want. They make hospitals make and spend decisions for clinical care individually. So as patients move around, there needs to be adjustments for volume as it changes over time. And this, I will say, is one of the more complicated and controversial mechanisms that are in place. So the biggest volume change that occurs for any hospital are changes in the demographics, the size of the population, its geographic, its age composition. So there is a demographic adjustment to the global budget. There is what's called a market shift. So this is to take into account to a small degree, in some cases, some would argue not sufficient, when a patient goes from one hospital to another. How much of that global budget gets moved as that patient moves from one area to the other? And what happens when a hospital closes a program, eliminates a program, moves a program somewhere else? Moving that volume around is important. When volume isn't moved and the global budget is there and people have reduced volume appropriately, what's left is what we refer to as retained revenue. So actually, hospital retained revenue has increased. Their ability on the regulated side of activities has increased. As we'll see, hospital volumes have declined fairly steadily under this model. Hospital readmission rates have gone from being among the worst in the country to being below the national average for Medicare. And as a result, the inpatient footprint has changed. That in itself has also led to other problems. Well, so we'll leave the question of volume for a moment, but the key takeaway here is that this is not a global budget payment. It is a global budget cap under a fee-for-service market. We also build it. I'm sorry. Yep.
Well, I'm looking at your retained revenue comments, and that it's the ups and downs of the market shift. Sort of the ups and downs of any budget correction that we might have. And if you've got greater volume one place and based on demographics, whatever, set age, whatever, that then you need to shift the money. How frequently does that occur?
So the adjustment occurs annually as part of the update factor. I will say that during COVID, it happened more frequently, and it was actually one of the great advantages that the global budgets had during this pandemic. So what happened with COVID? Very rapidly, volumes declined. People did not want to go to the hospitals. Hospitals cut down a substantial amount of their inpatient and outpatient elective activities. Volumes fell. Elsewhere around the country, what did that mean? Well, revenue fell precipitously. And the federal government had to step in and look for making payments rapidly to hospitals. In Maryland, as volume fell, revenue remained the same. So unit rates went up, but hospitals kept their volume. So they were not adversely affected financially to the same degree that hospitals were nationally. And that was critically important at a time when hospitals were struggling to try to respond to how to operate under these extraordinary circumstances. We also were able to stand up, as many places were, a very robust telehealth initiative. I was at Hopkins at the time that COVID broke out, and for years had been encouraging us to do much more in the way of telehealth. We can't get it done. It'll never happen. It took 2 weeks for us to stand up telehealth activities. So I will say the volume, going back to the point at hand, the volume in times of crisis were great. When volumes fell that precipitously, unit rates went up. Other adjustments that go into this are, well, over time, how efficient are these hospitals? Are they efficient both in terms of their per capita performance? So how does their per capita performance appear? And how does their unit rate appear? So you can be what is called technically efficient. So you're producing services in a technically efficient manner. And are you at the same time producing per capita spending for total cost of care in an efficient manner. And so, again, without getting into the complexities, and it'll blow your heads up, we have a mechanism in place, again, albeit imperfect, that tries to evaluate that and adjust for that. For hospitals that become inefficient in their technical efficiency or inefficient in their per capita or global budget activities. So very briefly on the results, and I've included a link here in the PDF electronic version that shows this. Came from Mathematica. This is the report that was done a little less than a year ago on our progress under the total cost of care model. I circle here because this is a comparison of the last 2 years of our model before total cost of care went into effect with 2019 to 2022. So obviously period of time during COVID, but beginning to come out of COVID. And we could see that our performance relative to the prior period was generally in the direction that we wanted it to be. Medicare fee-for-service spending was better. Total spending and non-claims payments were better. Outpatient spending was better. As you would expect, non-hospital spending relative to everything else went up. And so we don't consider that to be a bad thing. If you're reducing and moving things away from hospitals into non-hospital settings, that's not a bad thing. All-cause admissions were down more rapidly, again, as you would expect. Outpatient and ED visits and so forth. So generally speaking, it has improved. I also included in here an exhibit that they look at in terms of how the performance is relative to the Medicare standard. We have produced about $1 billion in savings above and beyond what Medicare required us to produce as a result of this, as a result of the contract. And so we have saved them money. They may think that it is not enough money. Our Medicare rates are higher than the rates. Per capita spend is higher, in part because it is all payer. All payers pay the same rate, but we are making it more affordable by bringing down that utilization. So in a way that Medicare then can save money on use. I think Elliot Fisher talks about the squeezing of the balloon. Our idea here is we're trying to reduce the size of the balloon overall. So if you contract in one area, it's okay to expand in the other as long as that balloon is not blowing up overall. So that's our performance activity. So our fundamental challenge is, how do we create, this is really the challenge of any global budget mechanism, how do you create the results of a well-organized prepayment model? So think of a Kaiser program is probably the best known example, particularly Kaiser in California, or Kaiser where they have control of the delivery system for their patients, both inpatient and outpatient, but you're doing it without capitated payment. If we had capitated payment and as patients moved from one health system to the next, it would not be an issue to worry about changes in volume or adjustments for those types, because the payment mechanism will work. Medicare knows how to do that, for example. It's called Medicare Advantage. They have a mechanism to do this. What we're trying to do here is to create those same incentives, but in a fee-for-service payment under an umbrella of a global budget. And to say that this is hard work is an understatement. It's very difficult work, and I commend you, particularly in the discussion that you had earlier, for making sure that you take the time to do this properly. So what I'm going to spend the last moment of my time with you talking about, in as fair a way as I can, are the strengths, weaknesses, opportunities, and threats of this system, a SWOT analysis. And I like to think about those as the strengths and weaknesses are things that are internal to our system, and external are things that are outside the system. So how does the regulatory system work, and what are the opportunities and threats outside of it? So let's talk about the strengths. Well, obviously, longevity helps. You've been around for a long time. People know what to expect. There are known quantities. There's no major adjustment to things. There is a huge infrastructure in place. The data that is collected by the Rate Setting Commission, by the Planning Commission, by CRISP, by hospitals, how it is collected and presented and made available. That infrastructure is been in place for many years and is robust, and people trust it. There is no question about how we operate and sharing things in a transparent way. There isn't, because as much fear of anti-competitive behavior, again, because you have a regulatory structure. It is all payer. I stress this all the time. The fact that it is all payer means that the incentives that you're putting in place are felt across the board. And it is both a strength, and we'll talk about it, as a challenge here going forward. How do you make something that is not all payer now into something that is all payer? It is not easy to do, but it is a particular strength, because when you set an incentive, say it is for readmissions or for emergency room wait time or for overall spending, you're doing it across the board, across all payers. I talked earlier about our HIE CRISP. I think that, again, that is a portion of our infrastructure, but I wanted to call that out separately. We have seen very specific results, both in total cost of care and readmissions, that we can point to that the system has achieved. We have achieved what we have set out to achieve in terms of savings for both Medicare and for all payers, and for readmissions, and for some, albeit not all, of the quality metrics. And we'll talk about some of the quality metrics that have deteriorated. And we've also generally enjoyed great political support from our governors, both Republican and Democrat, and we have strong support, have received strong support from our Maryland congressional delegation, again, over the years. People have seen value in this. And I mentioned already our experience under COVID-19. I think that was eye-opening for many people to see how the system could respond. And because it was local, we responded within days of COVID, of making sure rate orders were updated. Hospitals had what they needed. We were on the phone constantly with hospitals, and it was something that was really, I think, something we can be very proud of. So what are the weaknesses? Well, to say this system is complex is not giving enough emphasis to complexity. It is really, really complicated. And as a result of that, it is difficult to understand. I used to say that you could make the system simple by having one set of rates and one global budget for everybody, but that wouldn't be fair. So how do you develop something that is both at the same time fair and understandable? And because of that, it becomes something that is very difficult to replicate. I think the discussions that you've had earlier about using reference pricing as a way to get this done, making those reference prices available to be able to see and to establish, is certainly one way in which you can, you on the revenue side of things, can make things operate well. The volume policies I've alluded to before, I don't think that they are sufficient. I think they have created some imbalances. After a decade of doing global budgets, we have not gone back and reevaluated in a wholesale manner whether that revenue is being appropriately spent and available. There have been considerable differences in how volumes have moved about in services that have been closed or relocated, and that remains an area of big concern. In particular, the language that is used now is that this system has to pay for needed or necessary volume. Unnecessary care or potentially unnecessary care should not receive that same treatment. But if patients need care, that needs to be paid for. I've talked about retained revenue. We've talked about that before. Notwithstanding what I said about COVID, the system, not because of these weaknesses, has not been as rapid to respond to these concerns expressed by hospitals as I think it ought to, and that is driven in part by staff, in part by the commission. You've talked about this in your legislation, and an area where I think, again, our system has failed. The MHCC has not done the type of planning that is necessary, that is as robust and timely, that ought to be in place, particularly as it relates to capacity imbalance that is built up over time. We have too many, in my opinion, too many facilities in Baltimore City, particularly as volume has declined, not enough emphasis on primary care capacity, and how we move that around, again, in a system that still relies on private actors to move quickly, has not been sufficient. Physician alignment. So all of this talk that I've made so far has been about hospital spending. Obviously, physicians are the drivers of much of that spending. They are the ones that initiate an admission. They are the ones that provide care within a hospital. But the regulatory authority of the commission does not extend to physicians. And I say physicians in at least three broad categories. One are hospital-based physicians. So when you go to the hospital, you will see an emergency room physician, a radiologist, a cardiologist, an anesthesiologist, a hospitalist. Those are physicians who are within the hospital that are paid through the hospital, but the rate-setting commission does not have authority over them. And what has happened over time is that those physicians, particularly in recent years, significant burden placed on hospitals by these groups, sometimes by private equity activities, that have placed hospitals in difficult financial circumstances because they need unregulated revenue to make up that difference. And the only place that they can get that revenue is becoming much more efficient on the regulated side, and it has created huge problems. Hospitals come in to the commission asking for rate relief, and the commission has to say, we don't have authority over this. So this is a particular problem area, in my opinion. So the first category is hospital-based physicians. The second category, I would say, includes physicians who are on call, particularly in emergency rooms, to provide that type of oversight, whether it be for neurology or for other specialty services that are available in the emergency room. To have on-call physicians become available, it creates a similar problem to the hospital-based physicians, albeit these are not physicians who are based at the hospital. And then finally, more broadly, physician practices that may be being purchased by physicians, independent providers, and so forth. That is not within the system. We do have a number of bundled payment models, upwards of 100 different bundles at this point, and rapidly expanding. But that is the degree to which there is that alignment, and that needs to be much more greater aligned in my view. And now a problem that has emerged that is particularly problematic is ED wait times have spiked in Maryland to the point where we have some of the longest ED wait times in the country. And this is just not an acceptable outcome. Now, we're focusing attention on it. We've the commission is focusing attention on it. They have established various work groups that have physicians there, and in hospitals as part of it. It has not yet been resolved. Not surprisingly, some say, well, you need to give us more money. Others say you need to improve your outcomes. In any event, it is not been resolved yet. So what are the opportunities? Well, I think there are lots of opportunities ahead for improved alignment.
John,
Yeah, let me
John,
stop.
I'm gonna, if you don't mind, I'm gonna ask to move a little bit faster along because we've got two
Yep.
more.
Gotcha. I'll be very quickly then.
Okay,
I'll move
good.
very quickly then. Very quickly.
Thank you.
Opportunities, improved alignment across payers and providers. Although we are all payer, we can do a better job of incorporating private providers and Medicaid. That's part of AHEAD. And providers, I've talked about physician alignment. Medicaid is now going to move to their own primary care model, notwithstanding having a primary care model for Medicare. And then clearly we need more delivery system reform. I mean, if the goal in payment is to change the way in which the delivery system operates, that is what we need to see more of, and make those incentives more clear, and to make the system. I don't use the word simpler, but I think the system has to be much more understandable. That whoever the regulators are have to understand how these incentives play out in the real world and how they are affecting operations and how hospitals and physicians and others are supposed to operate under it. Finally, I think we need to use some of our savings to innovate. That's one of the advantages. If we're creating excessive savings, we need to go back and invest in things. And some of that is happening now in some very exciting models I can talk about in the Q&A section. And then finally, in terms of threats, at this point, I don't need to tell this committee, there is a lot of uncertainty in Washington. We have an AHEAD contract. We have a waiver with the federal government. We don't know how the new administration is going to respond to this and what the political challenges are going to be. So with that, I can move on to discussions. I can stop sharing and answer questions that you may have. I apologize for going a little bit longer.
No, it's okay. And what you've given us is really a terrific look at the system in place in Maryland. And there are certainly some similarities to what we're doing, but also to some thoughts that are going on as we're looking at the legislation and the regulatory scheme. So this helps us a great deal. Obviously, we can't do it for every state. It would be great if we could, but thank you. This is terrific. How much time do you have? What's your availability right now?
For today, I can probably go for another 20 minutes or so.
Okay.
But I stand prepared to help the committee in ways that in any ways that I can.
Thank you. Okay, so what I think we'll do is we'll see if the committee has questions of you, and then we're going to take a very short break, and then come back to our next folks. So committee, questions. I guess I do have one. So your overall, if you were going to give us an overall recommendation, and you've looked at the sort of the framework language and some of the places that we're thinking about going, and then the timeline piece that has been identified this morning, what would be your recommendation for us in looking at the total cost of care, global budgets, alignment of payers and providers? What is the place you would go to?
So I think a lot of what you have included in this legislation or proposed legislation makes a great deal of sense. I would heed the advice you heard earlier today. And that is to make sure that you are paying attention to the planning aspect. You only are going to get what you are planning for. And if you get people in advance to understand what are the principal goals, what are you trying to achieve, that can be done relatively quickly. But it is a process that has to include the various stakeholders. And I would write those in ways that are broad enough that they can change over time, but clearly have to be done in advance. So that's point number one. Point number two that I heard earlier today was the idea of then, once you have that accomplished, beginning to fold things in incrementally. You can certainly create the statutory authority in one fell swoop. there's advantages to that you know what you're going to be doing, but have it implemented in a way that you can test and readjust over time and make sure that things are working. Having that infrastructure in place is absolutely essential. That's, again, if you're going to have people move to reference-based pricing, how are you going to assure that people are in compliance with that? How are you going to be sure that what those reference prices are? What do you do in the case when they are not compliant with that? How do you assure that that is achieving? Do you do that exclusively for hospitals, or are you going to do that as well for other components of the system? And then how do you establish what those global budgets are and then enforce the global budget? So again, as I said, we do adjustments each year for volume, including capitation and inflation. But how do you do that again if you're doing it underneath a rate system that sets these reference prices? So it'll take some time to do it. So my advice is do the planning, develop a comprehensive bill, but implement it over time.
Thank you. That's helpful, truly, and we appreciate your time and information. This is terrific. Any other questions from the committee? I think a lot of this is helping to put people onto the page and begin to help us understand next steps in terms of specific legislative language. So greatly appreciate it and your time. And we may come back to you at some point, and I hope that you might be available to us.
I very much look forward to it. And I'll be an attentive listener at this point.
Oh, good. It's great to have a lot of different people around the table. It's truly helpful. So thank you. Okay, so committee, we're going to go off live and we're going to come back here at 10:30 when we listen to Elena Verby, who is very patiently on screen.